Well, thank you for inviting me to be here. It's great to be here to see friends and meet new people and talk about a couple of my favorite things, blood pressure and ambulatory blood pressure monitoring, which, there's going to be a little bit of overlap between my two talks, but I tried to make them different. So this talk will just focus on when do we use ambulatory blood pressure monitoring in pediatric kidney transplantation and how does it help us? And I guess before I start, how many of you are routinely doing ambulatory blood pressure monitoring following kidney transplant? So a minority of people. Okay, great. Well, hopefully I will convince you all to start doing it when you're at the end of the talk. So I'm going to talk a little bit about ABPM. I'm going to go through that very quickly because I assume most people know about it. Then how it's used to detect hypertension after transplant, the correlation between what we see in ambulatory monitoring and intermediate outcomes, and then how you can use it to manage patients. So start with a description of a patient. This is a 6-year-old boy who had gotten a living-related kidney transplant. He had ANCA-associated vasculitis for his cause of end-stage kidney disease. He came in for a routine checkup about 6 months after transplant. He had normal kidney function, which you can see there. He had been on some amlodipine already. And at the clinic visit, he had one blood pressure reading at the 95th percentile for his age. All of his other readings had been normal. So we did his ambulatory blood pressure study, and this is his study, which I know it's too small for you to see. So what it showed was, this is, remember, a 6-year-old boy. His mean awake blood pressure was 122/88, mean sleep blood pressure 112/74. His blood pressure loads were between 50 and 100%. He had blunted systolic blood pressure dipping. So how does that relate to, taking blood pressure? So we know that there are a lot of problems with taking office blood pressures, body position, activity level, room temperature. I think all of our blood pressures are probably 5 points lower right now because the room is so warm. Cuff size, what device, oscillometric versus auscultatory. If you're listening to the blood pressure, do you have observer bias? I want the patient's blood pressure to be lower, or terminal digit preference. So we know that office blood pressure measurements have some inherent problems. Ambulatory blood pressure monitoring is a procedure in which the patient wears a device, takes the blood pressure at a regular interval over 24 hours, allows us to look at the patient's blood pressure outside the office during their usual activities. I had a patient the other day who said, I'm going to do some weightlifting today while I'm wearing your ABPM. Is that okay? I'm like, yes, as long as you put the monitor underneath you so the weights don't hit the monitor. It allows us to identify specific blood pressure phenotypes, which we'll talk about. We use it to confirm the diagnosis of hypertension, and we know that ambulatory monitoring results correlate with target organ effects of hypertension in both adults and in children. These are just some different devices that are out there on the market. They're small, they're relatively quiet. They take many measurements over 24 hours. Usually for us, if the patient is really good, we'll get 60 or more readings in 24 hours. And there's lots of different devices out there. The real benefits are that it overcomes the problems that I talked about with office blood pressure measurement. it's a machine. There's no terminal digit preference. There's no observer bias. It allows you to look at the patient's blood pressure pattern, identifying patterns like white coat hypertension, masked hypertension, and nocturnal hypertension. It gives us clues into detecting secondary causes of hypertension. And although we won't talk about it today, it allows us to evaluate the patient in a more cost-effective manner. So we talk about blood pressure phenotypes. I use that phrase frequently, and the phenotype is combining the office and the ambulatory blood pressure. And so you can see in the grid there that depending upon whether the office or ambulatory blood pressure is normal or elevated, you have 4 different phenotypes ranging from normotensive to ambulatory or sustained hypertensive, white coat hypertensive, or masked hypertensive. Okay, now, when is it endorsed? So in the American Academy of Pediatrics guideline, we endorse using ambulatory monitoring in a variety of circumstances, including confirming the diagnosis of office hypertension and ruling out white coat hypertension, to evaluate blood pressure patterns in patients who have high-risk conditions, and all solid organ transplant patients fall into that category of being candidates for ABPM. And then to assess how well the patient is treated. And this is particularly important in kidney transplant patients after they've been diagnosed with hypertension and started on therapy. Now, people have looked at ambulatory monitoring in transplant for many years. This is an old study by my friend John Soroff, but it's very illustrative of what you see. So they looked at 42 children at where he was at that point in Texas, and they showed that the blood pressure loads were high for both systolic and diastolic blood pressure, that they were much higher compared to control subjects, and that many of these patients had non-dipping. Dipping is how far the blood pressure drops during sleep, should be at least 10%, but they found that 80% did not have nocturnal dipping for systolic blood pressure and half for diastolic blood pressure, and they actually saw reversed dipping in several patients where the sleep blood pressure was higher than the wake blood pressure. And so then when you look at many studies that have been done since then, you come up with a table like this that I published in an editorial a few years ago, which goes over multiple studies that have been done up to that point. It's a little old now. I have to update it. But just to show you a few points on this table, that if you look at the percentage of patients who were hypertensive by ambulatory monitoring, it ranges from about 25% to almost 90%. So that ambulatory monitoring is picking up a large number of patients with hypertension. And then when you look at how many of those actually had masked hypertension, okay, where the office blood pressure is normal, but when you look at the 24-hour study, that's abnormal. The studies that reported it reported that between 20 and 70% of their patients who were hypertensive by ABPM, it was masked hypertension. So you would not pick up the hypertension in those patients without doing ambulatory blood pressure monitoring. And then this is a more recent paper, which was a study from the Paediatric Nephrology Research Consortium in the US, 6 centers combined, where they looked at how these patients were classified by ambulatory monitoring. And basically you can see that almost none of them, I guess I don't really have a pointer. Oh, I do. almost none of them had white coat hypertension, 1%, 25% of them had mast hypertension, and then many of them had ambulatory hypertension, and all of these unclassified patients, which was because of the prior AHA classification, which was a mess, which we have fixed. And then many of them here, if you look at their blood pressure load, half were normal, but again, a huge percentage had mast hypertension. Now, it's done in adults as well, and this was a very interesting study done in New Zealand where they said, well, let's look at ambulatory monitoring in our transplant patients and see what it tells us. And they actually found that patients whose blood pressures were, whose office blood pressure, this is not without blood pressure, but with office blood pressure at target, 75% of them had abnormal ambulatory blood pressure monitoring, and that 1/3 of them had mast hypertension. That of these with mast hypertension, this 58%, 1/3 of those had isolated nocturnal hypertension, which again is something we see very commonly on ambulatory monitoring. And when they looked at ABPM and used the results to manage the patients, 40% of their patients had a change in management based on the ambulatory blood pressure study result. And we see that in children as well. Now, here is again some data from the group. I think this is the same. No, this is this is a single center study, I think from Cincinnati, where they looked at blood pressure status in their transplant patients and looked at ABPM blood pressure phenotype and then kidney function. And what they saw was that, just looking at the bottom here, is that this group in the center who have mast hypertension had lower GFR no matter what equation you wanted to use to estimate their GFR. They went through like 5 different equations, but all of them were lower in the mast hypertensive group than in the normal blood pressure group. And in the sustained hypertension group, was even lower, which they didn't do any statistics because they had such a small number of patients with ambulatory hypertension. So showing that in patients who have mast hypertension on ABPM, they actually have impaired kidney function compared to patients whose blood pressure is normal on ABPM. And so then what can you do and how can you use it? How does it help you? So this is a study that was done in the Czech Republic where they looked at how they were able to, what was the change in the patient's blood pressure over time using sequential ABPM and then adjusting therapy based on the results of the ambulatory blood pressure study. And what they showed was that they actually didn't see much of a change in their daytime blood pressure here on the left-hand set of bars. And then, but they did see some decrease in the daytime diastolic blood pressure over time. But most importantly, they saw improvement in the nighttime blood pressure over time. And what that then enables you to do, because many of these patients actually have mast hypertension on the basis of their sleep blood pressure, is that fewer of them have hypertension over time if you're then using the ambulatory blood pressure study to modify their therapy. And they showed that as you looked at their blood pressure over time and you looked at their kidney function, those who had, those whose uh, blood pressure remained normotensive over time had better kidney function than those whose blood pressures were hypertensive over time. So again, showing that effect of hypertension by ABPM on kidney function in kidney transplant patients. Now, there are other studies that have looked at other ways in which you can use ambulatory blood pressure monitoring to manage patients and improve outcomes. This is actually the study for which I wrote the editorial where I made that table, where this was a study done, I think, in Italy, where they looked at just a small number of kidney transplant patients who had very careful assessment for intermediate markers of cardiovascular disease. So they had ambulatory blood pressure monitoring done. They had carotid ultrasound done to look at the carotid intermedial thickness, and they had echocardiograms done to look at LV mass. They had a control group who just had carotid ultrasounds done. So they did ABPM annually, and every year they would look at the ABPM results and they would adjust the treatment based on the ambulatory blood pressure monitoring results. And these were initially young patients, but they then got to be quite older, so some of them had to be switched to adult criteria because they actually then studied them 9 years later after doing this for 9 years. And they looked at their blood pressure status, their carotid intermediate thickness, and then their LV mass 9 years after using this ABPM guided therapy. And what they showed, which I know it's too small to tell on this, but they actually showed that the CIMT was higher than the control group at baseline, so here, but on follow-up, after using ABPM-guided management, they actually had a decrease in the carotid intermediate thickness, which was statistically significant and then equal to those patients, the younger patients' baseline carotid intermediate thickness. And they also showed that they had a decrease in their LV mass index at the last ultrasound, and the number with LV hypertrophy had decreased from 6 out of 22 to 1 out of 22. So they had a decrease in the prevalence of LVH. And the same thing was seen recently in a study from the 4C group, where they looked at kidney transplant patients in the 4C study, and they looked at just about 3 years of follow-up, and they did something really interesting. They looked at blood pressure under the curve, and they used and they calculated that for systolic and diastolic blood pressure, and they also have been doing ABPM guided management of their patients. And what they showed was that blood pressure that was continuously below the 60th percentile was associated with a decrease in LV mass index and a reduced proportion with left ventricular hypertrophy, very similar to the Italian study from 10 years ago. And this is where they showed that the blood pressure percentile had those who had LVH, more of them had blood pressure in the 90th percentile in the red compared to those without LVH over time, where it was 43% versus 15%, and then 21% versus 2% for diastolic blood pressure. Now, there was one study done in the Czech Republic where they looked at sort of mimicking ESCAPE for transplant patients, where they looked at standard control of blood pressure versus intensified control of blood pressure. And they actually saw not much of a difference between those two groups. I'm going to actually talk more about this study in the next talk. And then the other thing that's interesting to think about is, should we use chronotherapy? These patients have nocturnal hypertension. So the question then becomes, should we be dosing their antihypertensive medications at nighttime? Or should we be giving them an extra dose of something at night? And what's really interesting about this is, I'm going to talk about the one pediatric study that is published, which I was a reviewer for and wrote an editorial about. Because what was very interesting is that this has never been done in the adult transplant literature. Okay, this was never done, but there was a small pediatric study, and I'm just going to summarize this slide by saying it didn't help. They converted patients from non-dipping to dipping, but had no effect on the outcomes they looked at, and I'm going to show you a little bit more detail in the other talk. So, sort of putting this together, we know that post-transplant hypertension is common. We know that it's very frequently detectable by ambulatory blood pressure monitoring, that the value of ABPM is that it detects these circadian blood pressure abnormalities like blunted and reverse dipping, isolated nocturnal hypertension. We know that the target organ effects of hypertension correlate with ABPM findings, and these things include reduced kidney function and left ventricular hypertrophy, and that ABPM-guided treatment can improve some of these intermediate markers of cardiovascular risk. Now, here's my patient. I actually got to see him again 11 years later. He still has his mother's kidney, or his aunt's, I think it's his aunt's kidney. Yeah, his mother is a nephrologist. His mother's a nephrologist. This was a very stressful transplant. So they showed up at my clinic 11 years later, because he'd been bouncing around for other people. Still has a decent level of kidney function. Home blood pressure is good. And now, this is his ambulatory blood pressure. This is, I swear this is the same patient. I am not making this up. So 11 years later, he was switched to candesartan. And I'm going to talk about that in the next talk. And he has great ambulatory blood pressure and office blood pressure and stable kidney function. And so he's a success story. Oh, I just made it a little bit bigger there, but you can see a nice ABPM, and you can see we changed software programs. And thank you for your attention.
Thank you very much. That was an excellent talk. Any questions? I'm sure there will be a few.
There you go, Manish.
So, Joseph, thank you for a very nice talk. So, I'm sure you get asked this all the time. So, what should be our target for the blood pressure for these patients? Should we go by...
I'm going to talk about that in the next talk.
Okay.
So I'll ask you two very quick questions. One,
I know, it's a little hard. I mean, I offered 2 talks, but they're so, intertwined. It could have been one 90-minute talk, but that would have been way too much to ask you to sit through. Yeah, Steve.
I was going to ask you two very quick questions.
Yeah.
One, do you remove those episodes when patients are doing exercise, or do you include them in your overall data? Do you want to answer that?
Yeah,
first?
well, it's a good question because the reason to do ABPM is to capture their blood pressure on a usual day, right? So if that kid who I saw on the other day, on Thursday, is weightlifting, every day, then we should know what that does to his blood pressure.
And then my second one is, should we stop measuring blood pressure in hospital? Should we not just use home blood pressure and ambulatory blood pressure monitoring?
If you're asking me whether blood pressures obtained in the inpatient setting are useful. I will tell you they are not. And that oftentimes in the clinic, they're not useful either. Except probably in Manisha's hypertension clinic and our hypertension clinic, where we actually are paying attention to it. Yeah.
Thank you. Excellent.
Thank you. So we'll move on to the next talk, which is actually the plenary lecture. And that's titled Epidemiology, Pathophysiology, and Treatment of Post-Transplant Hypertension. Looking forward to that. Thank you.
Okay. Great. All right. Oh, this one I did the whole fancy thing, no disclosures. But I will be discussing off-label use of blood pressure medicines. Okay, so for this talk, we're going to try to hit actually 4 areas, not just the 3 that are in the advertised title, because I can't not talk about the impact of post-transplant hypertension on the allograft, and then pathophysiology, and then treatment. So prevalence, how frequent is it? Well, I'm actually going to start with a slide about adults, because I think it's useful sometimes to think about that, and we take care of a lot of, well, maybe you all don't. You transition your patients at what, 16, 17? Yeah, we keep our patients until 21 at a minimum. But anyway, we see a lot of young adults, but you know, sometimes it's good to know what our patients sort of look like when they get older, and what our patients look like when they get older, or what adult transplant patients look like, is that they're all hypertensive. All of them, basically. So I highlighted here the different studies. The ones where the prevalence is lower were old, and the more recent ones where the prevalence is 60 to 90% are current. And so it's sort of bleak. Well, in children, it's not much different. And I don't need to tell this audience how frequent it is. So we're going to start with just the overall kidney replacement therapy population. Because I really like this study where they looked at children in Europe who were getting hemodialysis, peritoneal dialysis, and who had received a kidney transplant. Because remember, those are the 3 possible therapies for kidney failure. And when they looked at just what the blood pressure distribution is, okay? So these graphs show the blood pressure distribution. I'll make this a little bit bigger for you to see. And just talking about the transplant patients, so about 30% of transplant patients overall had blood pressures, these are measured blood pressures that are 90th percentile or higher. And then when you look at in the middle group of bars, those who are on blood pressure medicines, it's about 40% of transplant patients on blood pressure medicines have measured blood pressure above the 90th percentile. And then when you look at those not on blood pressure medicines, about 15% of them, 15 to 20% of them have blood pressures above the 90th percentile. So just like in every other stage of chronic kidney disease, post-transplant patients frequently have high blood pressure, and frequently it's not detected, and frequently it's still high even when it's being treated. And I'm going to then talk about Dr. Sinha's study, because he's sitting right in front of me, that looked at the United Kingdom experience. And so this was a really neat paper to read. I wonder how many miles you put on your Mini Cooper, because they went actually to visit all the centers. Probably all of you had Manish or his team visit you. This is great, I thought. And a great way to make sure you're getting complete data, no doubt. So they looked at the blood pressures retrospectively, 6 months, 1 year, and 5 years after kidney transplant. And on average, about 27% were hypertensive at each time point. And it really wasn't any different between 6 months and 5 years. Maybe slightly different, but it was really about the same. And if you then, and those were, I think, the measured blood pressure, right? And so then when you added in those who are being treated for hypertension, it was close to 50 to 60% were actually could be diagnosed as hypertensive. The antihypertensive medication use actually decreased over time, which I thought was odd, because a third of those on medication were still hypertensive. And then there was a big center effect, which basically for those young people in the audience, it means that there was a lot of variability between centers, which actually impacted their statistical results and had to be accounted for using some fancy funnel plot things, which I don't really understand very well. But when you're doing a multi-center study and there's a lot of variability between centers, that can actually have an effect on your results. Okay, back to the present. And so here's some data from their paper, and just to show you a couple things where what were the factors that they found that were associated with hypertension. So short height, which I imagine is because the high blood pressures weren't being recognized in the shorter children, something which we've just published out of the CKID cohort, actually. And then donor source, where deceased donor patients were more likely to have hypertension compared to living donor patients. Most likely, I would assume, as we'll talk about in a little bit, this is related to different immunosuppression, probably higher doses of calcineurin inhibitors and corticosteroids. And then this is a graph where they looked at blood pressure z-scores at the 4 different time points after transplant, with the black part of each bar being those not receiving blood pressure medications, and the gray bars, no, black on medicine, gray off medicine. And just showing that there is this pesky group whose blood pressure is above the 95th percentile at every time point. And actually, I would say you have two pesky groups, because those above the 90th percentile is probably not good for them either. So that you actually have, you know, a big number of patients at every time point who have abnormal blood pressure. Okay. What about other places? So this is a more recent paper from the CERTAIN registry, which is a registry study in Europe. I don't know a lot about it, but this is a really nice, they published recently a paper about their experience, and they looked at blood pressures after transplant. And again, just to show you that even at 3 years after transplant, they had actually, I should have just circled the bottom part, because the bottom part, the bottom 23% not in the circle are the ones with normal blood pressure. And so what they're showing you is that 70% of their patients in their registry have hypertension at 3 years after transplant. And then if you look at some American data, this is from the North American Pediatric Renal Trials and Collaborative Studies Registry from 10 years ago now, because I haven't published anything recently even though I keep asking them to. And this is just different medication use after transplant, which is interesting to look at. So antihypertensives in deceased donor transplants is the highest, right? The most frequent. And then right underneath that are antihypertensive medications in living donor recipients. You can see 60% in the living donor recipient group, even out to 5 years after transplant, and about 70% in the deceased donor group, even 5 years after transplant. These are unpublished data. Don't tweet this slide, from our Improving Renal Outcomes collaborative registry, where we looked at blood pressure control status after transplant. And you can see it's divided up into those with normal measured blood pressure, those with abnormal measured blood pressure, those on medications, and those off medications. And what we've outlined in the yellow are all of those you would say have hypertension. It's about 56% are on blood pressure meds or have uncontrolled blood pressure in the IROC registry. And then one interesting thing to think about are the normative data you're using to classify patients as hypertensive. So again, this is an analysis, unpublished analysis from the IROC registry, where we compared using the prior normative data from the fourth report that are being carried forward in the ESH guideline for some unfathomable reason, versus the updated normative data in the 2017 AAP guideline. And you can see that actually fewer patients are classified as normotensive and more patients are classified as hypertensive. And this is because of the lower normative blood pressures in the 2017 AAP guideline compared to the old guideline. All right, and then, so that all of those data are really based on office blood pressure measurements. So and then I've already showed you this, slide from the prior talk about it being even more frequent based on ambulatory blood pressure, and many of them have masked hypertension based on abnormal nocturnal blood pressure. Fine, so this is a common problem no matter how you measure the blood pressure. What is it doing to the kidney transplant itself? Well, it's doing a lot of bad things. So here is, again, that study I showed you earlier where we looked at blood pressure phenotype and kidney function, and we showed you that those who have masked or sustained hypertension have reduced GFR compared to those with normal blood pressure on ambulatory blood pressure monitoring. So kidney function is worse. And then again, from the Czech Republic, showing you that those who have hypertension over time have worse kidney function compared to those with normal blood pressure. And then what about other aspects of things we look at after kidney transplant? We look at kidney function, of course. We look at graft survival, which I'll get to. But how about some other markers of cardiovascular risk? Because it's more, we have to think about these things as well. Because we know that the #1 cause of death in our patients is going to be heart attacks and strokes. They don't die from their kidney failure. They die from cardiovascular disease. So it's very important to think about these intermediate markers of cardiovascular risk. So this was an old study, but very, very important, I think, because it looked at LVH post-transplant and how it changes over time. And so this was a retrospective single-center study, again from Cincinnati, where they looked at echocardiograms about 1 year, 3 years, and 4 years after transplant. And what they found is that many of these patients at LVH initially, it actually tended to persist, but it got less severe. And they showed that systolic blood pressure was an independent predictor of LV mass. And just looking at their echo data, so here they're showing that LV mass did decrease over time. That's in here, but that the percent with LVH stayed the same. And remember, this is from almost 20 years ago now. So these would have been patients, and these were patients with up over 5 years of follow-up. So these would have been patients transplanted in the around 2000 or earlier, before there was widespread use of ABPM. And then this is their LV mass index over time, showing you that it did tend to decrease over time, probably with treatment of hypertension. But they didn't really talk about that in that paper. Here's a more recent paper where they did look at that. So this, again, is the 6-center study from the Pediatric Nephrology Research Consortium in the US, where they looked at LV hypertrophy and kidney function according to blood pressure treatment. And what they showed for both blood pressure, LV mass, and GFR was that those who had hypertension off medication, that there was worse LVH based upon if they had higher blood pressure, whether they were on or off blood pressure medications, and that kidney function was worse in those who had higher blood pressure, masked or sustained hypertension compared to those with normal blood pressure. And this was a very recent study, recent paper we published in the journal that I thought was really interesting because they looked at vascular stiffness. Now, vascular stiffness is a very interesting problem because I think that it's one of the initiating factors in target organ damage. And we've shown some work in non-transplant patients from our Schipholhoit cohort that patients with increased vascular stiffness tend to have more target organ damage like LV hypertrophy and even changes in cognition, although that's not published yet. Anyway, this is, again, a European study where they looked at vascular stiffness and blood pressure evolution and what happens over time. And what they showed was that if the blood pressure goes up over time, the vessels get much stiffer over time, which is likely one of the things that then leads to LV hypertrophy, which leads to graft damage. And so it's very interesting, and I think requires a lot more study. Okay, how about allograft survival? Well, again, I'll start with an old paper, which I think is a very important paper because it actually sort of predicts what is to come. And so this was a retrospective study from Cincinnati of patients, a 20-year cohort of kidney transplant patients where they looked at those who had hypertension and those who did not. And they showed that hypertensive recipients had much worse long-term graft survival compared to normotensive recipients, that they had those who had systolic hypertension had more graft failure regardless of any other problem. It was an independent predictor of graft loss. And that, independently predicted graft loss. And then if you look at what they did in these two graphs was divide the patients into those with and without hypertension. and they looked at graft survival over time. And the dashes don't show very well, but the bottom lines on each graph are those whose blood pressure is above the 95th percentile, and you can see how much more graft loss there was compared to those whose blood pressures were below the 95th percentile. And then this is a fast forward to only 10 years ago. This is a study from Minnesota, University of Minnesota, where they did sort of the same thing. They looked at, well, actually what they looked at was antihypertensive medication treatment. But so those who are hypertensive, which are in the dash lines, and these lines you can see better, also had poorer graft survival over time, up to 20-year follow-up, compared to those who were not on blood pressure medication. And this was true for their overall cohort, for their living donor cohort, not as great an effect for the deceased donor patients. So it's not good for your allograft. Now, why do we have this problem? Here we go. For the rest of the talk, I could again keep you here for the rest of the day, but I promise not to. But I like this cartoon because it really sort of puts things into context and categorizes them. And we know that there are multiple factors that can lead to hypertension in these patients. So things like how well the kidney is working, the immunosuppression, and so all of these things on this side are the immunologic factors, but there's lots of non-immunologic factors. Things like what happened with the surgery? Did they get 20 liters of fluid, which is always obviously going to affect their blood pressure in the immediate post-transplant period? Did the surgeon do a good job in anastomosing the kidney artery, or is there transplant renal artery stenosis? And then things like the donor, did dad who donated the kidney to his daughter actually have masked hypertension, and that now his daughter has the same problem that she inherited from her dad's kidney? And then did the recipient have hypertension or other problems that lead to hypertension? So a lot of different factors can actually sort of come together to lead to hypertension in the recipient. Now, this table sort of divides things up in a little bit different way, from recipient factors, donor factors, to transplant specific factors. And I'm going to focus for a minute on the medicines, because I think it's important to understand the effect of the medications on blood pressure in our patients. So starting with corticosteroids, are you all using steroid-free, or does your protocol include steroids? Free. Every patient, even high risk? Okay. Interesting. Okay. So we know that glucocorticoids are associated with post-transplant hypertension. There are many different mechanisms, all obviously the same mechanisms that make any patient treated with corticosteroids have hypertension: activation of the mineralocorticoid receptor, activation of glucocorticoid receptors on smooth muscle cells, and I think activation of the renin-angiotensin-aldosterone system. We know that it's dose dependent, because in adults, less than 10 milligrams a day of prednisone doesn't cause hypertension. And we know that patients on alternate day prednisone have less problems with hypertension than patients on daily prednisone. This was a study where they looked at steroid avoidance and incidence of hypertension, and they showed that those who were steroid-free had much less hypertension at different time points compared to those who had steroid-based regimens. This is their preliminary paper. They actually ended up, I think, publishing this paper and then abandoning steroid-free immunosuppression because of risks of rejection. Although we still do steroid-free immunosuppression in Seattle for our low-risk recipients. Our high-risk recipients get steroids. Now here's another study from the Pediatric Nephrology Research Consortium where they looked at cardiovascular risk factors in patients and they compared those transplanted under steroid avoidance protocols compared to steroid-based protocols. And what they showed was that both systolic and diastolic blood pressure were lower in the steroid-avoidant group, and that the number of antihypertensive medications were lower in the steroid-avoidant group. And here is just showing you the blood pressures, so that even out to 3 years post-transplant, the steroid-avoidant group had lower systolic blood pressure and lower diastolic blood pressure compared to those who were transplanted under steroid-based regimens. Now, how about calcineurin inhibitors? Well, first, I want to shatter a myth. The myth that tacrolimus doesn't cause hypertension is not true, okay? If anybody walked into this room thinking that, don't you dare walk out thinking that, okay? Because it has the same. This is a study done in I think a study in children looking at, could be adults, I forget, I apologize. Looking at rates of hypertension based on whether or not they were on tacro or cyclosporin. And cyclosporin's a little bit higher in the green for both diagnosis of hypertension or on more than 2 antihypertensive medications, but it's not very much different, okay? And then I was really happy to see this paper come out last year, which is a meta-analysis of calcineurin inhibitors and multiple complications after transplant, and just focusing on post-transplant hypertension. So all of these bars are crossing the center line in the meta-analysis, and there was basically no difference in rates of hypertension in those receiving tacrolimus compared to those receiving cyclosporin. So does anybody now believe that there's a difference? Okay, good. Now, why does this happen? And why is it the same between the two? And the reason why it's the same between the two drugs is because of all of the things that calcineurin inhibitors are doing that are non-immunosuppressive, okay? So we know that they cause, vasoconstriction, they lead to sodium retention, they activate intrarenal renin expression, they increase the expression of endothelin, which is the most potent vasoconstrictor our body makes. They also interfere with production of nitric oxide, which is an important vasodilator. They lead to decreased synthesis of prostacyclin and increased production of thromboxane B, which is, and you can see there, vasodilator versus vasoconstriction. They increase sympathetic nerve activity, and when you're on them for a long time, they cause graft fibrosis. And I should have put chronic CNI because tacrolimus causes the same interstitial fibrosis and vascular lesions as cyclosporin. So this is from 2001, but you know what? It is exactly what happens, and we've known this for a long time. And so this is a nice cartoon, actually from a paper about heart transplants, but this was a really nice description of how actually calcineurin inhibitors impact multiple pathways, including renin-angiotensin system, sympathetic nervous system, endothelin, nitric oxide, causing vasoconstriction, affecting tubular function, infecting all these different, transporters in the distal tubule leading to retention of sodium and hypertension. So multiple mechanisms by which these drugs cause hypertension. Now, other things just to mention that are also relate to causes of hypertension, we have to talk about allograft things like obstruction of the ureter, rejection, ischemia, reperfusion injury, transplant kidney artery stenosis, in the long term, things like chronic allograft nephropathy, recurrent disease, de novo glomerulonephritis, donor vascular disease, and then, I guess, transplant renal artery stenosis. So we know it's common. We know what it does to the allograft. We know why it happens. How do we treat this thing? There's just like a hydra, right? It has so many different things to go after. So first of all, we can look at how to modify some of the things going on in the kidney. And so starting with calcium channel blockade. So calcium channel blockade, we know that systemically they lead to relaxation of vascular smooth muscle cells. Well, in the kidney, they actually help modify that calcineurin inhibitor glomerular, afferent glomerular arteriolar vasoconstriction. And when you look at the effects of calcium channel blockers in adults, because we don't have data in children, treating patients with these drugs reduces graft loss, improves GFR, and reverses LVH. And for that reason, for many, in many regimens, they're felt to be first-line agents. We know there are problems with lower extremity edema if you put them at 10 milligrams of that amlodipine. And we know that if you give them with cyclosporin, it'll make their gums look bad. But otherwise, they have very many good effects. One thing just to remember, I'm sure you all know this from working with your intensivists, is that nicardipine will muck up your tacrolimus levels. And our kidney transplant patients are the one patient group we don't use nicardipine in after transplant because we start our tacro on day 1. I don't know what you do. And then long term, you have to worry about diltiazem and verapamil if you're using them. But most of the other calcium channel blockers don't affect your levels. And again, it should be CNI levels. Why? I look at these slides 10 times and I didn't fix them. I apologize. What about RAS blockers? What might make us think about using them in a kidney transplant patient? So we know that in general, they lower proteinuria. They do that because they reduce the interglomerular capillary pressure. We know that they lower hematocrit, which can be good in these patients. We know they're cardioprotective. They have somewhat of a potassium problem in some patients. They can increase the creatinine. They can lower the hematocrit. And then we know that ACE inhibitors can lead to cough and angioedema. So we know those things about these drugs. But what about in transplant patients? What happens if you treat transplant patients with these drugs? So it helps. And so I'm going to couple adult studies that looked at use of ARBs specifically. So this was, I think ARBs and ACEs in the next one. So this was a retrospective analysis of use of losartan in about 300 transplant patients. When patients were on losartan, they had lower blood pressure, and the decrease in GFR over time, which is naturally seen following transplant in adults, was slowed. And they did that by plotting 1 over serum creatinine, which many of us used to do in the old days before we could actually estimate GFR. They had reduced proteinuria, and they didn't really see any bad effects. They didn't really see problems with potassium or uric acid or hematocrit. Now, this study is comes from the Wisconsin Allograft Recipient Database, so it's really big. 2,700 adult transplant patients, and they were able to pull out 400 of them who were on RAS blockade compared to about 2,300 who had not. And they showed a reduced hazard ratio for graft loss of 0.6, 0.7 for death. For death, okay? Death was less common in patients treated with RAS blockade for both total graft loss and death-censored graft failure. That's huge, right? And of course, it was better in those with proteinuria, more benefit in those with proteinuria. They did see some hyperkalemia. Now, and then what about kids? So this is Blanche Chaver's paper from Minnesota that I showed you earlier. And so they showed that patients who were on treatment for hypertension had worse outcomes. But then they looked at the class of antihypertensives they were getting. And guess what this dotted line is? ACEs and ARBs. ACE or ARBs had better graft outcome compared to not being on an ACE or ARB. So you can almost say that all of their graft loss in their patients with hypertension was in patients not treated with an ACE or an ARB. So think about that for a minute. Not only should these things be in the water, they should be there should be a poly pill for transplant patients with these drugs. Okay, and why is this so beneficial? This is sort of putting this together a little bit. But as I was talking about earlier, a lot of it is related to intraglomerular hemodynamics and how the effects of calcium channel blockade and ACE inhibitors counteract the effects of calcineurin inhibitors. Okay, now you want to know about blood pressure. Oh, and then, of course, a lot of patients do need combination drugs because it can be, these patients can have quite severe hypertension because, they come to transplant already having been hypertensive or already having been on dialysis. They don't have normal blood vessels. So it's hard to actually effectively treat their blood pressure. So just like treating any other patient with complicated hypertension, you may need to use combination therapy. All right, what about treatment goal? I was asked about this by my friend there. So I went to look at guidelines for treatment goals. And so KDIGO in its transplant guideline actually had a goal, which I was really surprised. And they had a goal for children. They said less than 90th percentile, if less than 18, which is based on office blood pressure measurement. And then they say for use any class of drug, but if there's proteinuria, can use an ACE or an ARB. So that's 10 years ago or 14 years ago now, but they haven't updated it. It's the only transplant guideline KDIGO has done. How about the European Society of Hypertension? What do they say? So this is a pediatric guideline. So they recommend calcium channel blockers as the initial drug, but they have no other specific treatment recommendation in terms of a goal. So you would assume that the CKD goal would apply, because by definition, all of these patients in our transplant clinics have CKD. So that's what you would assume. About my guideline. Well, guess what? We didn't really talk about transplant patients either. But so therefore, our general goal of less than 90th percentile would apply. But then, we looked at the ESCAPE data and we endorsed the ESCAPE goal for transplant for CKD patients in the AAP guideline. But when we were talking about this in IROC and trying the Improving Renal Outcomes Collaborative and trying to decide what goal we were going to use for controlled hypertension based on ABPM, there was a lot of unhappiness with 50th percentile of MAP because people are concerned about hypotension, particularly overnight in these patients. So our consensus was 75th percentile on 24-hour MAP. So I don't know if that answers your question, but that was, and I think that's still reasonable. But we need a study, basically. And then this is the study I talked about, well, if we did an escape trial-like study in transplant patients, would that help? So in this study, they randomized a small number, and this is probably one of the problems with this study, is it's way too small, of transplant patients to strict blood pressure control versus usual control, so less than 50th percentile or less than 90th percentile on ABPM. They had ABPM every 6 months. These kids must be angels. None of my patients will do it every 6 months. They were all on ramipril, and then they added amlodipine if they had proteinuria, and then amlodipine, then ramipril if there was no proteinuria. They only got to their target in about two-thirds of the intensified control group. But there was no effect on primary outcomes, no difference in proteinuria, no difference in rate of eGFR decline, and one might almost say that it was detrimental to the allograft, because look at how quickly their GFR dropped in that first year in the intensified blood pressure control group. So it makes you wonder whether that is actually a good thing to do or not. Okay, let's talk about chronotherapy again. So this is, as we've talked about, nocturnal hypertension is frequent, blunted dipping, they all have it. And in the general population, this is not good for you. In adults, we know that non-dipping and nocturnal hypertension is associated with increased rates of stroke and death and bad things like that. And in the general hypertension literature, this is very controversial as to whether to use chronotherapy. There's one group from Spain that says it helps. Everybody else thinks that that group is crazy or falsified their data. Okay, this is serious. And so it's very controversial. And if you look at adult kidney transplant patients, it has never been studied. There was one pediatric study, so pediatricians leading the way, although I'm not quite sure to where. This was a small study at 2 centers where they screened all of their patients for non-dipping, and so 60% of them had non-dipping, no surprise. And so they randomized them to an extra blood pressure medicine at bedtime, in addition to whatever else they were taking. And I think they used short-acting medications like enalapril and isradipine. I'm pretty sure it was enalapril and isradipine. So they gave them an extra dose. And what happened? Well, yeah, they got them to dip, but there was no effect on their outcomes of interest. And so this I pulled out of their table because their table is just unmanageable, and they didn't have any nice figures in the paper. But so here is the data. So in these columns are where their patients were at baseline. And then here is their data follow-up at 6 months. And so you can see in the intervention group, they went from all non-dipping to only 47% non-dipping. So they got a lot of them to dip. But they still had a lot with nocturnal hypertension, and maybe this was the problem. Their LV mass didn't really change, 49 to 45. The percentage with LVH didn't really change, 35 to 33. And then their pulse wave velocity, because they looked at that as well, didn't change. And so although they got the patients to drop their blood pressure, they didn't see any benefit. And I had real ethical problems when I reviewed this manuscript, because I don't think giving an Alpro at bedtime is healthy for a kidney transplant patient, because they don't drink always overnight, and you're potentially really dropping their blood pressure quite low. And so I personally don't think this should be done. What I really think we need to do is use the ambulatory blood pressure study and modify their overall antihypertensive therapy. So if they're hypertensive overnight, then they need a higher dose of their angiotensin receptor blocker, or they need a second blood pressure medicine added. They don't, for the day, they need a second once daily blood pressure medicine added. Now, some of my patients actually who are on two medicines, some of them split it up with something at nighttime and something in the morning, and it's fine. I tell them I'm not particularly interested. I'm going to prescribe for you medications that, at least in theory, are once a day medications. So all I really care about is that you take them. And whether you take them in the morning or at night is less important than whether you're taking them at all. And I'm sure that we would probably say that about any medication that is only dosed once a day. All right, I'm almost done. So let's talk about putting it all together and managing these patients. I didn't talk about post-op blood pressure management because we all know it's because the surgical team gives too much fluid. So you have to dry them out and make sure that the surgeon did a good job in hooking the renal artery back up. And so after that, if you talk about in the first 6 months post-transplant, you're going to screen them with office blood pressure, ABPM. All of our patients get ABPM 6 months after transplant at Seattle Children's. Calcium channel blockers are our first-line drug, and often those are what's added in the early days based on office blood pressure. And then if we need to, we may add a diuretic, or we may add a beta-adrenergic blocker because of the activation of the sympathetic nervous system. And then after 6 months, that's when we'll either add or switch to an ACE or an ARB. Like the little 9-year-old boy I saw last week, still hypertensive, still has some LVH now at about 14 months after transplant. It got better on amlodipine, but I switched him from amlodipine to olmesartan because he has a little touch of proteinuria too. You could continue their calcium channel blockers, and then you should be doing ABPM, I think, to guide your therapy. We do ambulatory monitoring every year in patients on therapy and every 2 years in those who are not on therapy at Seattle Children's. So all of our transplant patients know that ABPM is part of their follow-up because we feel it's that important. So hypertension's frequent. We know it has significant detrimental effects on allograft survival and other things. Treatment should probably be aimed at normalizing the blood pressure, just like in patients with, lesser stages of CKD. Calcium channel blockers, ACE inhibitors, and ARBs, we've talked about that. We often need to use multi-drug regimens. And then the things I think that are unclear are what should the goal be and whether or not we should use chronotherapy. I think the small pilot study was too small and not conducted in a way I would have preferred to really be able to answer the question. And I thank you for your attention, and I think we should all have lunch.
Thank you very much. That was a beautiful talk. Any quick question before lunch?
Did I
Okay.
answer your question?
Oh, now that we're on. Yeah. Oh, is
Great.
that was that a joke or a? Yeah.
No, it was because he had asked a question about goal.
I see.
I mean, office blood pressure is going to be important as well. And, you know, I think we've shown, at least in the, and you've shown even in your work, that lower office blood pressure is helpful in slowing CKD progression. And, you know, like I said, all these patients have CKD. So, you know, lower is going to be better. And so if you get them to a normal office blood pressure, that's the first step.
So just related to that, do you think if there is a study to be done, do we have to chase a kidney function target, or do we have to chase a, hypertension blood pressure target? Because, when you talk to the transplant doctors, they are more concerned about kidney function, like you showed. What
Yeah.
would be better?
Well, clearly you're going to be studying both. And I think the only way you could do that study is really to have the blood pressure target be the basis for the intervention, but have kidney function be one of the outcome variables. And then, but also, you know, obviously in these days you're going to look at vascular stiffness, you're going to look at LV mass, and look at cardiac function and some of the advanced measures of cardiac function using tissue Doppler, and then probably vascular stiffness and even, atherosclerosis. I mean, it really needs to be done in a comprehensive way. Big undertaking. And it can't just be a natural history study. There's lots of value in studies like CKID and 4C, but you can't, in those, although they're large cohorts, they're actually too small to be able to sort of model a clinical trial. You need big data to be able to model. In a retrospective sort of or a natural history study, you actually need very large numbers to be able to model a clinical trial. So you actually then need to do a prospective study to get the data that you need.